Howdy. My name is Joseph Clark. My project is the implementation of end-tidal CO2 monitoring, or EtCO2 monitoring, on mechanically ventilated patients. So my hospital currently doesn't have end-tidal CO2 monitoring for all ventilated patients outside of ACLS. So they use it to determine ROSC for ACLS, but outside of that, we do not use end-tidal CO2 monitoring for mechanically ventilated patients. We rely instead on daily atrial blood gases. So ABGs are accurate, but they only provide a single snapshot moment of the patient's blood gases, which can delay recognition of dangerous CO2 levels. So the patient could be hypocapnic or hypercapnic essentially all day. So long as they started going down or up in their CO2 levels after that morning ABG, we wouldn't know until the next morning ABG. Which could be really harmful for the patient because hypercapnia and hypocapnia can both lead to neurological injuries and even death. Hypocapnia is there's a definite correlation to patients who are hypocapnic and they have a higher mortality rate in ICUs. And it's very difficult to assess these patients of hypocapnia because the early assessment is altered mental status, and these patients are intentionally sedated to have a decreased neurological response. They have what's called RASS of between 0 and -2. So it would be very difficult to detect early ETCO or early hypocapnia, but EtCO2 monitoring would accomplish that task. Research has consistently shown EtCO2 monitoring closely correlates to PaCO2 and can detect changes earlier than ABG. So while EtCO2 is what they're breathing out, the PaCO2 is going to be what's actually in their blood. But there's a very strong correlation there. It's so close that even if it's off a little bit, it's off by such a minuscule degree that it's still reliable enough to get to show we need to get an ABG, and then we'll be able to make changes based off that ABG. Keep in mind, we're not planning on making ventilator changes on the EtCO2 monitor. The EtCO2 monitor is just going to notify us to get an ABG, so that way we can see what the patient's really looking like at this point. Moreover than just giving us when they become, outside of normal, it can also help trend us. So, like, let's say they are borderline hypercapnic, but then they start trending down and down and down and down and down. And 4 or 5 hours later, now they're borderline hypocapnic. Well, yes, they're still technically within normal limits, but they're changing. And it's good that we can address changes sooner rather than later, especially if we're trending everything like that. So this is something that organizations like the AHA and the Intensive Care Society, they already recommend EtCO2 monitoring for safe airway management, which supports, and they support expanding the use of EtCO2 monitoring to all mechanically ventilated patients. So implementing continuous EtCO2 monitoring for all mechanically ventilated patients to act as an early warning system and at the moment to complement daily ABGs. Eventually, we can see about potentially even doing away with daily ABGs. We may no longer need them. There's a hospital in Cincinnati that has completely eliminated the use of daily ABGs, and they have found that they've been able to reduce patient cost significantly because doing ABGs every single day adds up. And instead doing non-invasive EtCO2 monitoring and making adjustments to the vent based only when you require to do an ABG based off the EtCO2 data is a bigger cost benefit to the patient as well as the hospital itself. So the expected benefit is going to be an earlier detection. So instead of doing daily ABGs, we're going to do end-tidal CO2 and then do a stat ABG whenever we see a trend or outside of normal parameter, and that'll prompt us into getting that getting that stat ABG to adjust the mechanical ventilator, so that way we can put the patient back into a normal limit of not just CO2 but also pH. We'll reduce ABGs. We'll also save money for the hospital as well as the patient. This will decrease invasive procedures and also have better patient outcomes as well. Um, so the plan to get this taken care of. Um, so first off, we need to talk to the different people that are going to be involved. So that the managers, both of the ICU manager, the respiratory therapy manager, um, any of the managers that are going to be over the staff that this is going to affect, we need to get their buy-in, and also we need to get any kind of adjustments done that they may have in mind. We need to go talk to the board of policy for the hospital as well. Once we start implementing this policy, the way it's going to look is the RTs are going to monitor the equipment side of things. So the EtCO2 monitor itself, which is going to attach to the ET tubing. And they're going to determine if the EtCO2 monitor needs to be changed out sooner than it should be, which it'll get changed out daily at the current proposal, along with all the ET tubing every morning. And while the RT is monitoring the equipment, making sure that is working appropriately, the nurse will be monitoring the patient. So what does that mean? They're going to be monitoring the CO2 level of the patient as indicated by the EtCO2 monitor, and they will be monitoring the ventilative status of the patient, meaning that we're going to, look at the waveform of the EtCO2 monitor and say, hey, is this a normal respiration? Is this hyper tachypnic? Is this bradypnic? Is it apneic? And that's going to help us determine if tube placement is appropriate. And this is also going to be a more accurate determination of ventilator status or ventilation status than what we're going to be getting on the ventilator itself. So once this plan goes into progress, there'll be a 1 month period that this is going to trial. After everyone gets on board, we've done education for the RT, how to manage the equipment, do education for the nurses, how to monitor the CO2 levels, how to monitor the respiration status of the patient based off the EtCO2 monitor, which that will take 2 weeks to do education. But the rollout policy will last for about a month. Will last for a month, and it'll take about 2 weeks to go through the data. What we'll be looking for is to say how many times did a patient go into a critical hyper or hypocapnic state without this policy in place. And then for the month that we do this policy, we'll say how many times has a patient gone into critical hyper or hypocapnic state. Or even a critical pH level would also be something worth looking at as well. We'll be looking for a reduction of critical levels that patients have gone into either hyper or hypocapnic, because we'll be able to adjust settings before they get to that point. Whereas with daily ABGs, it could be 18, 20, 22 hours before we realize they're trending that direction. And so I suspect that we'll find that patients are going into critically hyper or hypocapnic state more often now than we would like. And then once this data has been digested, if we as a hospital look at this and say, yes, this is something that is worth implementing, then we will do quarterly audits to make sure that over 95% of our ventilated patients have EtCO2 monitoring, and that we are reporting the appropriate levels to the providers. And if we're above 95% quarterly for a year, then we'll go to annual auditing. But the hope is that we will be able to increase patient outcomes by not allowing them to go into critically hyper or hypocapnic states, period. We should have 0 because we'll be able to see the trend line coming and we'll be able to adjust before they get close to critical levels. But final message here is that EtCO2 monitoring strengthens patient safety, supports evidence-based practice, reduces costs, and enhances ICU care. This is a valuable and necessary improvement for my hospital. I'm excited to start working on it with the hospital itself. I'm excited to show everyone what I've been working on. And I hope you guys have a Merry Christmas coming up.